Thank you. Welcome to this session. I am Dr. Tarin Ahmed is welcoming you to this session on diabetes in children. Our speaker is Dr. Bedowra Zabeen. She is a consultant pediatric endocrinologist and coordinator of changing diabetes in children of BADAS. The session will be chaired by Professor Kishore Azad, eminent pediatrician. She is a project director of perinatal care project of BADAS and honorary senior consultant, Department of Pediatrics, BARDA. I now request Professor Kishore Azad Madam to start the session. Over to Kishore Azad Madam, please.
Assalamu alaikum. Can you hear me? Assalamu alaikum and good morning to this session on diabetes in children, which will be presented by Dr. Bedowra Zabeen Lisa. Lisa qualified from Sylhet Medical College in 1991 and then did her FCPS in pediatrics from the Bangladesh College of Physician and Surgeon in 2006. She joined Burden in 1995, and I'm very proud to say that I have guided her through her journey in Burden until a few years ago. She also went to Australia and did postgraduate training under Professor Kim Donahue, who is a very renowned diabetologist in Westmead Hospital, Sydney. Now, Lisa runs the projects CDIC, which is Changing Diabetes in Children, as well as LFSC, which is Life for a Child program of the International Diabetes Federation. She has more than 50 international publications in peer-reviewed journals and also in domestic journals. She is both a member of ISPAD and APES and has made international as well as local domestic presentations in many conferences. I would like to invite her to make her deliberation now. I must say that I'm very proud of having tutored Lisa. She is one of the very able students who has crossed the threshold where I've been training and looking after children. I no longer do so. I've now become a full-time researcher, which is why I'm in perinatal care project. Lisa, the floor is yours.
Assalamu alaikum, a very good morning. I must show my gratitude to my mentor, Professor Kishore Azad, for her kind introduction. And very good morning and assalamu alaikum to all our teachers and colleagues who are listening to this lecture. So my topic is challenges in childhood diabetes management, how to overcome. I have nothing to declare. Well, when we speak about children with diabetes, first of all, children, we can see how many stages or ages they're passing through, from the infancy to childhood, then adolescent. And at the same time, when they are diabetic, we can understand how difficult it would be or how challenging it would be to manage children with diabetes. So this is the outline of my presentation. So we already know that unlike adults, most children are type 1 diabetes and they need insulin for survival. So insulin should be started as soon as possible when the diagnosis of type 1 diabetes is confirmed. There is no chance to delay to start of insulin, of course. If we look into the scenario of diabetes in Bangladesh, In Bangladesh, we know that almost in adult diabetes it's 8%, and there is actually no definite data on diabetic children, but estimated is 4.2 according to IDF Atlas. And we did a small study in our clinic, and we found that more than 15 years incidence is 1.24 from the registry we got it. So the challenges, social and financial challenge are big challenges. If you look into just a house of one of our patients in Bangladesh, we can see the poverty is one of the major challenge, unavailability of the insulin, lack of education, and lack of awareness and false beliefs, familial disharmony, social barriers, especially for girls, and difficulty in marriage, of course, especially for girls, is another social challenges. I just want to share one case of our children. That is, she was a 17-year-old girl diagnosed as diabetes 5 years back. She was forced to get married, having her diabetes, and actually due to family pressure, what happens generally. And husband, when came to know about that she was diabetic, he started physical and mental abuse, and ultimately she got divorced. Another case I want to share, 16-year-old girl, father died, and she was again forced to get married at the age of 16 years. And she was to take insulin, hiding others in the in-laws' house. And her HbA1c became high for last month, like more than 14% when she came for follow-up to our clinic. And her husband was a fisherman, and he noticed one day that she's injecting insulin, and he didn't allow to give her injection because he had a false belief that it's a bad thing to do, inject insulin. So we can understand how difficult it is for our children or girls, especially. And common practices we can see in underprivileged families, that you can see the entrance and how they are keeping insulin, because many of our children who are living in the village, they don't have the refrigerator to keep the insulin. And we can see the dietary pattern, that mostly the rice, that is carbs, and very little amount of protein or veggie they are taking. Now the financial challenges. Of course, this is another big challenge for us. If you look into the socioeconomic status of our children who are coming to our clinic, you can see that that is 100% were non-paying from 2010, and now only 8% can afford or fully pay the everything they want, like insulin or other supplies. So most of them are still cannot afford to buy or do anything about diabetes management. And 66% of family income who are coming to our clinic is below 10,000. And if we look into the minimum treatment cost of a patient, we can see that monthly income around 8,000 Bangladeshi taka. So we can understand how difficult it would be, or it's not at all possible to afford the whole treatment cost of a parent for diabetic children in our country, or in even Southeast Asia, I believe. Now the management challenge. That actually, this is the major challenge while you are doing pediatric diabetes. First of all, diagnosis is a challenge, because sometimes it happens that's type 1 or type 2 overlapping, because type 1 sometimes present with obesity, type 2 sometimes present with ketonuria, high blood sugar, and MODY or FCPD, because until unless you do the X-ray, sometimes we can't do in all patients, you cannot identify the FCPD patients as well. So diagnosis mostly in our clinic is on clinical basis. Pancreatic autoantibodies cannot be measured routinely, of course, and same for C-peptide. And there are also the other types of childhood diabetes, like we have, as a pediatrician, we see thalassemia patients, Down syndrome, other syndrome like Prader-Willi. These are also having high diabetic, and they need insulin as well. So it's a real challenge to treat a Down syndrome or to treat thalassemia at the same time to treat diabetes. So we usually do the clinical criteria for diagnosing type 1 diabetes, like patients presenting with abrupt onset of typical symptoms of diabetes, that is polyuria, polydipsia, weight loss, and severe hyperglycemia, of course. and requiring insulin for blood glucose control, and no acanthosis nigricans. Usually they don't have the type 1 diabetes, and usually they are non-obese. In contrast with Western countries, our patients are infrequently having diabetic ketoacidosis. We have seen in some studies we have done that 10 to 15% cases present with DKA. And of course, there is an emerging problem that is type 2 is rising. Like the Western world, we are also having high type 2 now in our clinic. From 2010 to 2015, it increased almost 7-fold. So management of type 1. Yes, we can look into this picture that insulin and monitoring goes side by side. So multiple daily dose, like minimum 3 to 4 times or even more sometimes, and needs to test capillary blood glucose test at home, at least 3 to 6 times initially. So it's a big challenge, I should say, for the parents, for the healthcare professionals, and also for the child. And again, second question is, what will be the regimen? Because sometimes we have to stick to twice daily, because some patients, those who are not coming for follow-up, they don't understand or they don't want to give insulin sometimes, but very rarely we do twice daily nowadays, but 3 times minimum and multiple daily injection. So when we have to, as a clinician, when you have to start insulin, you have to consider age, patient's age, duration, dietary patterns, exercise schedules, how they are active or not, school and work communities, patients' family preferences, and of course, individual needs. Sometimes we can give pump, but it's a very expensive one. So we give in very few patients are having pump now. And of course, difficulty in monitoring blood, because first of all, you are starting insulin. At the same time, you are telling, okay, you have to do blood sugar daily, at least 3 to 6, sometimes 7 times or more. So it's a really big challenge for the children and parents as well. And yes, dietary habits for the Southeast Asia, and especially in our country, is very difficult sometimes, because mostly they are used to with the carbs and fast food, whatnot. So, and also there is irregular meal timing, not taking 6 meals a day, because we always advise them to at least take 6 times because they're taking insulin so much. And sometimes long schooling timing is another difficult to have the real healthy pattern of diabetes diet. Physical activity, yes, they have to do the physical activity, but almost we know in our children, they are now on the sedentary lifestyle behavior. That's a real big challenge for us to convince them that you have to be active. Yes, when you start treatment, then another challenge will come, that is hypoglycemia. And those who are young children is really, really very difficult, because they might have nocturnal or midnight hypoglycemia. Sometimes it may be very severe, even we can't notice. If you look into this CGM, you can see that at midnight they are having some hypos, because we can see the line is going down, the blood sugar profile. So it's a really big challenge for clinicians, especially in young children, I should say. When a child diagnosed at 5 years or below 5, or even 6, 7 years, it's really very difficult to manage hypos. And what are the causes of hypos, especially? The delayed missed meal or snack, not enough carb they are taking sometimes, too much of insulin sometimes, during or after exercise, can happen anytime, of course. Especially for young children, it can happen anytime. It might happen, they're doing exercise in the evening, in the afternoon, but hypoglycemia can occur even during sleep in the midnight. So it's a very difficult to manage hypoglycemia in some cases sometimes. So you have to give sometimes in the midnight snacks for these children. And hyperglycemia, of course, we should say, and as an endocrinologist, that hyperglycemia is always a main challenge in managing children, but especially when we are dealing with adolescents. You can see to CGM we have done, and how the fluctuation is there with the lots of hyperglycemia. So this always is very difficult to keep your HbA1c down in case of children. I know sometimes in adults as well. And DKA. Yes, it may happen. Risk factors of newly diagnosed is usually the younger age, delayed diagnosis, and those who are coming from lower socioeconomic status because maybe they are not aware of how diabetic children may present. And sometimes with known diabetic also we are having because of omissions in some cases and limited access sometimes to medical services, and of course when they are sick or intercurrent illness. So when the point of sick day is coming, this is another area, is another challenge, managing sick day in children, because often children are having respiratory tract infection, fever, diarrhea is very common in children. And we always should remember that with this illness, the child may progress to decay in some cases. So always we have to educate them how to manage a child when they are sick at home. And usually we advise them to do frequent glucose and ketone monitoring, even so frequently that is too early. And always we give this message to them, whatever they are sick, even they are not able to take food, but you shouldn't stop insulin completely. That's the real important message we give. And in Southeast Asia, also in our country, it's a major issue now, diabetes in special situation, that is Ramadan. Because we know that usually the children with type 1 are exempted, but they don't feel to be exempted for not fasting during Ramadan. And they insist they want to fast, even they're not having good control. So that's another challenge for us to manage the fasting in Ramadan for diabetic children. So we know this is always a dream for us, that the target, achieving glycemic control, HbA1c less than 7%, and preprandial, postprandial blood sugar. These are the current ISPAT guideline recommendation, and we usually advise patients to achieve the HbA1c, but of course it's very, very difficult. This slide I can show that basically we are having so much adolescence in our population. So when you are dealing with adolescent, you can understand there are so much important issues are going on with them, with the puberty, with the sex hormones, and with this diabetic management, the pressure from the family and from the healthcare professional is very, very difficult. And often they have the behavioral and emotional problems as well. And interestingly, in our population, you can see that we are having mostly the adolescents patients with type 1 diabetes. So you can understand how difficult for us to manage these children and adolescents. And of course, there are risks for vascular complications, mostly the microvascular we get, that is nephropathy, retinopathy, and very few cases we got neuropathy. And we know that when your HbA1c is going down, and of course, there is very less chance of having retinopathy and nephropathy. And this is the recommendation. We should start very early, that is 11 years or 2 to 5 years duration. We should start screening for the micro and macrovascular complications in type 1 diabetes. We had a study with 199 patients, and we had that high range of 25% microalbuminuria, and 3.5% was macroalbuminuria. And we did screening with more than 1,200 patients, and we found 5.6% having the early retinopathy, of course, early retinopathy, because this is very interesting because we are showing that microalbuminuria and early retinopathy. And we know that if we reduce the HbA1c levels, or we have good control of glycemic control, we can manage that. This will be, of course, this is reversible. It may go down. So after the management challenge, it is also part of management. That is because we know that children are spending their time mostly in the school at this age. So difficulty in the injection in insulin at school, because more than 10 years they can do their own, but there is no space in the school mostly in this Asian region and also in our country. And under chance, who gives? Who will give or who will supervise? Because you cannot let them do on their own. So it's a really difficult issue because the lunchtime probably most of the patients are having lunch at school, they have to give insulin, but sometimes they have to skip insulin, they can't give the injection. And at the end of the day, we are striving for the good glycemic control. It's very difficult. And in school, mealtime, yes, that's the problem. Physical activity is usually very less nowadays. And hiding diabetes from peers is very important because there's always fear of bullying and the lack of awareness and knowledge of school authority about diabetes. That's really a challenge for a child because school staff doesn't know how to deal with type 1 diabetes. And we don't have any school training or for teachers, or we don't have any nurse or educator in school. Psychosocial challenges is another big challenge for our children because they don't accept diabetes. They become very much emotional. And the emotional and behavioral problems is the major problem with them. Adolescent crisis, anger, self-harm, sometimes suicidal tendency, and conflict with family members, inattentive to study. Follow-up challenges is another challenge because 2/3 of our children are coming from outside the capital, that is Dhaka. And it's very difficult for them to travel this long distance sometimes, cannot afford to come to the center because they have to have that affordability, difficulty in doing lab investigation outside Dhaka, difficulty for day laborer to come, and girls, of course, need an accompanying person to come. And sometimes there is no holiday, school holiday, and on Friday, only they give the permission, but it's sometimes difficult from coming from them to the center. And difficulty to take leave. Those who are doing some job, difficulty to take leave for those who work especially. So these are the lots of challenges we can see in children and adolescents, but how to overcome? Because so many challenges I have shown. Of course, it's very difficult, but not impossible, of course, I should say. So first of all, what we have learned from this, that while we are dealing with a child, we need a team. And that should be a multidisciplinary team headed by pediatrician with diabetes interest or pediatric endocrinologist. We should have a diabetes educator, dietitian, they should be specially trained for children, psychologist or counselor, social worker, volunteers, ophthalmologist, other specialists, and researcher, of course. So what about diabetes care in Bangladesh? Children with diabetes mainly managed in adult diabetes or general medical outpatient clinics, except in Burdem Hospital in Dhaka. But nowadays, some are doing outside Burdem also. They have started some following up the type 1 diabetes. In Burdem, children are managed in the Department of Pediatrics since 1997. And the CDIC program of BADAS is providing the mainly comprehensive services for all diabetic children and adolescents since 2010. And we are running 2 programs side by side, that is Changing Diabetes in Children, CDIC, and Life for a Child. And the program is supported by Novo Nordisk, WDF, Diabetes Australia, and IDF. And we are seeing from 0 to 26 years of age, and we are providing free comprehensive and care to these children and young adults. So these are the key initiatives we have taken. Free comprehensive care to those who are underprivileged and healthcare professional development, because it is very important. You need a healthcare professional trained specially for pediatric diabetes, structured education program unit, and we have done, and a special counseling program, dietary, and everything. But and also, the BADAS always has a policy like cross-financing, that is fund generation. Also, we are seeing the paying patients as well under the same umbrella, and there are free diabetes care to most of the children. More than 90% are having free care. So I have shown that social and financial challenge is another big challenge for us. So we always try to involve social allies to create awareness among the society during the special days like World Diabetes Day and other days. awareness program in schools, because this is very important, I have shown, because the children are spending more time in schools. And we usually do the lectures and we give the poster of DKA posters and also the what are the common symptoms of type 1, these posters to the school authority. Camp is very important. Camp for the diabetic children, because they feel very good when they go for residential camp. There we give the education and also the entertainment, physical activity, everything they practice there with a very homely, non-hospital environment. And I have shown that 2/3 are coming from outside the Dhaka city. So we sometimes have to go outside for the center visit, so that we can do the follow-up and also the screening of these children. I will just show some slides for the impact of comprehensive care. We can see that more than 6,000 patients we are now dealing. We registered in the center. We can claim that, yes, it is the largest pediatric diabetes clinic. We give the diabetes daycare for those patients are coming for having ketonuria or hypoglycemia, or also we manage insulin pump in the daycare. You can see that we have introduced insulin pump under the same roof in the CDIC. And when you are dealing with children, we can see that we have to start early screening for the microvascular complications. So we are doing the screening in the same center. So it's like a one-stop service the children are getting. We are screening nephropathy since 2010, and we have started the fundal camera photography. We have an optometrist, and also the retina specialist come for 1 or 2 days, and they do the grading of the retinopathy screening. So we have started it from 2016. And this is the main challenge we are having. That is the metabolic outcome. Because at the end of the day, we want a good metabolic outcome so that we can prevent the microvascular complications which children are having a risk to have. So I will just show the 2019, we have screened 711 patients. We have analyzed the data. All patients, we can see the mean still is very high, that is 9%. But interestingly, when it is less than 1 year, it was better, 8.48. After 1 year, again, it rises to 9%. So in the first year, maybe they are doing the follow-up mostly, they are coming regularly. Gradually, everything goes down. I mean, there is negligence, maybe follow-up, dropout, something may happen, and the HbA1c again going up. So follow-up and dropout rate, to reduce the dropout rate is another challenge for us. And very interestingly, if we can see that as we see up to 26 years, we can see that from 18 to 25 years is better, at least. That is 8.7, not bad, I should say. So the thing is that this is the adolescent group I have shown that we are having. That's a real challenge for us to have good glycemic control. But when they're becoming young adults, yes, maybe they're taking their care or self-care. And when they are more than 25, you can see HbA1c went down more, that is 8%. So you can understand how difficult it is, and still we can work it out with the multidisciplinary approach. We can make it down, hopefully. So a trend of decay, if we look into this slide for from 2010 to 2015, that yes, new patients also decay. Maybe the awareness is more in the community now. The decay, new patient decay is also going down, and old patient is almost 50% we could reduce up to 2015. I can show the recent data is the previous data, but still the 50% of decay we could reduce in the known cases. And acute complication, this is also very important. The severe hypoglycemia is another challenge we know. And we can see that in 2019, only 2 per 100 patients had severe hypoglycemia. We can claim it's a very good outcome. And fasting, yes, they always insist. We have done some researches, and we could find very interesting finding that even they are having high HbA1c, but they could fast safely in the month of Ramadan. And at this COVID time, we started the telemedicine during the lockdown when Bangladesh had 2 months lockdown and our clinic was closed. And we found that the patients having hyperglycemia was the main problem, but there was no incidence of decay or severe hypoglycemia at that lockdown time. And also young people with type 1, they could fast safely. So in conclusion, I could say that social stigma, unaffordability, unavailability of the comprehensive service or care are major challenges for us. So awareness programs to create awareness about children with diabetes among the community and society is required. This is very, very important. We should make people aware to reduce the stigma. And creation of small unit diabetes care in different districts of Bangladesh and networking with the central diabetes care is really necessary. CDIC may play as a role model in further development of diabetes care in children and adolescents in Bangladesh. Of course, long-term sustainability plan is required because we have seen more than 90% cannot afford their management cost. Involvement of the government health services is important to take care of these diabetic children as well. Although this may be a huge task, but I don't think it's very impossible. We can ensure the resources and can overcome these challenges as well. Lastly, I must acknowledge my mentor, Professor Kishore Azad, for her positive thoughts and inspiration throughout this journey, for managing these difficult cases, and all our partners and donors, and finally my team, a wonderful team I have in CDIC with the healthcare professionals, with the multidisciplinary approach. And I always believe that together, it is a team effort, that is together with effort, we can achieve more and more. Thank you all for your patience hearing.